Oh, thank you very much, John, and good evening, everyone. It's really a pleasure to be back in Minnesota. We come back, Linda and I come back with some regularity, trying to time it so it's in the summer. And we've had just beautiful summer weather since we returned. A little bit about how I've ended up in this particular topic tonight is that the time that I've spent in Tanzania has really been formed and developed by what I was experiencing in the health needs of the people that we met in Tanzania. So when I first arrived there in the late 70s and early 80s, I was involved directly in community health programs and developing barefoot doctors to work within the rural communities of the Maasai. But we realized that as much as we were doing in the rural areas and in the villages, those people had nowhere to go for quality medical care. And so the next phase was hospital development and hospital financing in a resource-poor environment. Well, in the mid-'80s, we were overtaken by the new AIDS epidemic, which you all know hit Africa very heavily. And so AIDS and the care of people with HIV became our next phase and led into really my interest in palliative care. Because in Tanzania, for the first 25 years of the epidemic, there was no treatment. So HIV really was a terminal illness for the majority of people who were infected, and the only response we could give was in palliative care. Well, now, the AIDS epidemic, together with a changing epidemiology, has led to a new epidemic, a new challenge that's before us. And following the news, you all know what that epidemic is. It's Ebola. Now, I don't at all want to undermine this very important public health issue that's going on in Africa today. But I do want to point out that this epidemic, today I heard on the news that we have passed the 900 over 900 have died from this virus now in Africa. 900 people have died from Ebola. In this year, 2014, there will be 50,000 people who die from cancer in sub-Saharan Africa. Africa and Tanzania are moving at high speed into this new cancer epidemic. It's cancer, it's cancer, it's cancer. It's growing, it's overtaking us. And Tanzania is central, and our experience in Tanzania is changing to reflect that. You know, when I first arrived in Tanzania, our annual report every year was the same for about 15 years. The most common diagnoses were malaria, pneumonia, and diarrhea. Malaria, pneumonia, and diarrhea. Sometimes it was pneumonia, malaria, and diarrhea. Always the same. Last year, 2013, in our hospital, malaria ranked to number 35 on our list of diagnoses. And cancer had creeped up and creeped up and creeped up until it's in our top 10 now. Amazing increase in cancer going on in Tanzania. 500,000 deaths a year in the subcontinent, expecting to double by the year 2030. And soon, it will account for more deaths than malaria and AIDS combined. It's a phenomenal change in the epidemiology, the picture of health and health needs in Africa. And in Africa, this leads to unbearable suffering. Why? Late presentation. People aren't tuned into cancer as a problem to be aware of or to prevent or to do early diagnosis and treatment. They present very late stages of cancers. Women with breast cancer come in when it's finally fungating and coming out of their tissue. The little lump is not being evaluated. There's almost no care available. Cancer care is not available, leading to people who are suffering severely, dying oftentimes in great pain and anxiety in their homes. So how can we begin to change this? How can we reach out to the people who are in need? You know, in this country, over 80% of all childhood cancers are considered curable today. In Tanzania, less than 1% of our kids with cancer are being saved, are being allowed to live out normal lives. Phenomenal figure, cervical cancer of women is the second leading cause of all cancer deaths in Africa today. That's not just in women, that's women and men combined, and this one cancer in women accounts for it being the second leading cause of death for both men and women in Africa today. How do we reach out to these people? And what's fueling this epidemic? One is that in spite of the AIDS epidemic in some ways reducing the age expectancy, the life expectancies of our communities, there's another hidden group of the community which doesn't have HIV, and the public health interventions of immunization, malaria prevention through mosquito nets, better education, better health care, better women's health care is leading to another part of the population which is aging. And so we have an aging population, and the greatest risk factor for developing cancer is simply aging. And that's true in Africa and Tanzania as well. And changing lifestyle is another big issue. You know, we all have seen the specials on television of the Maasai herdsmen out across the plains with their animals. They're tall and lean, and they're walking many miles a day caring for their animals. But today, they're not. They're sitting in offices in Arusha. They're drinking lots of beer, having lots of roast meat with lots of salt, and now they're obese, they're hypertensive, they're diabetic, and their old lifestyle has passed by, and they are now at risk for the diseases of aging that they were once protected against. And the other big factor in Africa is that somewhere between 30 and 40% of our cancers are actually caused by viruses. So of course, the big one is HIV and AIDS, but also all the hepatitis viruses that can lead to cancers. The cervical cancer is caused by the human papillovirus. We have a large number of viruses that are causing our cancers. The good news about that is that to a greater extent than other kinds of cancers, there's potential for interventions. Those we can prevent, we can treat, we can change some of those risks. Tremendous limited access to care. We currently in Tanzania have one treatment center that's been in effect in Dar es Salaam. Second one has opened in a hospital in western Tanzania called Bugando. We're not sure how many patients they're seeing yet, but together they're providing care to less than 1% of the patients who develop cancer in Tanzania today. Huge obstacles for our people to get in for care. One, there are cultural and gender issues. How does one define when one is ill? Again, going back to, say, a lump in the breast for a woman, well, on the farm, on the shamba, back in the village, a woman who develops a breast lump is still perfectly able to carry on her daily tasks of getting the firewood and the drinking water and raising the children and milking the goats. It doesn't impact on her performance, so she's not perceived as ill. She doesn't get it checked out. The husband oftentimes is unwilling to invest the cost of sending her to a healthcare facility to have this looked at and tried to understand it. Plus, if they do go there, there's a great lack of understanding in the rural clinicians about what are the signs of cancer and what are the possible early interventions that might be taken. So there's a lack of awareness in the rural settings. And then the complications of the referral setting itself. The distances, the costs are quite large. If you can imagine somebody 1,000 miles away from Dar es Salaam in a little village at the end of a road, there's no transportation, telling them they need to get to Dar es Salaam for a treatment for their cancer, you might as well say you need to go to Minneapolis, because it's equally an obstacle to them to raise the money to overcome the the difficulties of transport, making their way through a major city and trying to get services, almost impossible. We have limited support facilities. Pathology and definitive diagnoses are few, and as I mentioned, difficulties in transport and the expense of traveling away. So as we look at cancer in this new epidemic in the African setting in Tanzania, really we'd like to see it based upon how cancer is arising in Tanzania. And this is really what FCCT is talking about as we look forward to being able to provide cancer care in northern Tanzania. It has to be based on the local epidemiology, which is quite different than what we have in this part of the world. It has to be made more accessible, overcoming some of those obstacles. And then it needs to be a spectrum of care that includes prevention, treatment, and palliation. I'm not going to spend a lot of time giving you figures, but I just want to point out, as you can see on this is cancer sites in Tanzania for males. And here in the United States, number one would be lung cancer, and number two, prostate, or maybe it's reversed now. Here in Tanzania, we've got Kaposi sarcoma, which is arising from HIV and AIDS. Esophagus, we see very little esophageal cancer here. Prostate is still high, and then things like colorectal cancer are quite rare still in Tanzania today. For women, again, this huge burden of cervical cancer. Breast cancer is high, the AIDS-associated cancers, and then again we see esophagus there. So traditionally, as we think about how we respond to cancer in the world or in our society, in our community, you can think about it as having three pillars. One of those is prevention, trying to prevent onset of reduce risk of developing cancers. Two is to have early diagnosis, early screening and treatment. And then third is palliative care for end-of-life care, those that have not been able to survive their cancers. Well, in Tanzania today and in most of Africa, we see a very skewed example of this model in that there's very little available or possible to do at this point in prevention, little being done in terms of prevention. Early diagnosis and treatment is almost non-existent, and so the main thing which is happening is palliative care is providing care for people at the end of their lives. Even though this is the dominant pillar in Tanzania, we estimate that, again, less than 1% of people with cancer who are dying from cancer have access to pain medication at the time of their death. So although we're making progress in that area, it's still very limited. So our vision is really these three areas of prevention, promoting prevention, developing treatment that's effective and accessible, and continuing with palliation. Some of the things we think about in terms of prevention is simply awareness raising in our communities, educational programs, training the doctors. Human papillovirus screening and immunizations is a new tool on the horizon, still a very expensive one, but it offers great hope for us in preventing cervical cancer into the future. Village level breast exams, not mammography, but just village level examinations. Talking about lifestyle in the different community settings, and then training our clinicians at all levels to be more aware of cancer and early diagnosis and referral. Early treatment diagnosis, really we're partnering with our friends and colleagues at the Kilimanjaro Christian Medical Center to establish a dedicated cancer unit and team there. We want to provide radiation and chemotherapy prioritized by the local epidemiology. So we pick out the top 3 or 4 problems that we're dealing with and focus on those in our community and in our treatments. And then we want to establish a new model of cancer care in Africa, which is a satellite hub and spoke type of setup where KCMC is the central point where the depth of pathology, radiology, training programs are based, and yet making accessible care available out at the ends of our spokes into places like Arusha Lutheran Medical Center in Arusha and other major cities in and around northern Tanzania. Of course, to do this, we need to have great capacity building. Volunteer staff and mentors will help with this, but the primary focus is going to be on the development of Tanzanian staff with specialties in oncology, the technicians needed, the nurses, the pathologists, and the palliative care staff. So capacity building is a top priority for sure. And always within the midst of this is our desire to strive to serve those who are most vulnerable. The mother or the child out in the rural village who develops a cancer, that they might be able to have that determined, that there may be a referral system that they can come in, that we can begin to save more of these lives, impact on the mortality and the morbidity both. And so our vision really is to reduce the suffering by establishing better prevention, better treatment and care, and continuing to expand our palliative care program together. And I really thank you for your interest in this and your support, because I do believe that together we can make a difference. We can stem the tide of cancer in Tanzania. We can make a difference, and I applaud you for your interest in doing that. So thank you very much, and I look forward to the evening together with you. Thank you.